Good afternoon. I want to start about on time because, as you know, this is a new session. This is quick shots, and we have not done this before. This will be a presentation that is limited to 2 minutes, and we have 2 more minutes for a question. Probably it's got to be one question because it is fairly short. So we have to be really staying on time, meaning that the first speaker, when the first speaker stops, the next speaker should stand right next here, wait for the question to the first speaker to leave, and then the next speaker to jump up here and continue. My name is Andreas Meier. I'm at SUNY Upstate. This is Dr. Biren Modi. He's at Boston Children's, and we're going to try to stay on time. So we may have to cut you off if you're over time. We have to take this pretty tight. A few other items. The folks who are scoring, the number 11 quick shot is not here. Unfortunately, the gentleman could not get a visa, and we would ask you at the end to bring us the sheets so we can drop them off with our leader. What else? I think there was most of it. If you, again, as in the previous sessions, if you want to ask a question, please state your name and your institution, because we need to record that one for the journal, but also for the video, so people know who's speaking.
I move the tribute, yeah.
I'm sorry, what? If you have the written program, the tribute will actually be after the 5th presentation, not after the second, not after the first. There was an error. I think that's it. If our first speaker wants to come up, please. The topic is, in quick short form, surgery in children with very early onset inflammatory bowel disease. Presenter is Dr. Kim, and co-authors are Adler, Herschel, and Galapali from the University of Michigan.
Thank you. Do I advance with the green button?
Yep.
All right. Thank you. We have no disclosures. Very early onset IBD describes disease that is diagnosed in children less than 6 years of age. Population-based studies in pediatric IBD report the incidence may be rising fastest in these younger children. Presentation as well as disease course also suggests a more severe phenotype in earlier diagnosis, as well as disease that may be more refractory to conventional medical therapy. Literature with regards to the role of surgery specifically within this earlier age group is limited and contradictory. To examine our institutional experience, we performed a retrospective analysis of all of our cases of VEO IBD enrolled between January 2009 and July of 2018 within a prospectively collected data registry. We excluded those with comorbid non-IBD surgical conditions, as well as those who had their surgeries performed at outside institutions. Of 723 children diagnosed with IBD, we found 10% were diagnosed at less than 6 years of age. Of those, 13 underwent surgery at our institution for final analysis. In our surgical cohort, the median age of diagnosis was 4, and the majority were diagnosed with ulcerative colitis. Almost 1 in 5 necessitated surgery for their inflammatory bowel disease, and over half of these occurred within 2 years of diagnosis. Stratifying for disease amongst all VEO with a diagnosis of UC, 16% necessitated colectomy within 2 years of diagnosis. For comparison, in larger pediatric UC studies, they report up to 20% colectomy rate in 5 years of diagnosis. In our cohort of 13, all but 1 necessitated surgery for medically refractory disease, as well 23% suffered complications. In 7 years of follow-up, 23% necessitated additional unanticipated surgery, and almost a third had a change in diagnosis. In summary, children with VEO IBD may necessitate earlier surgical intervention. As well, they may be more likely to have a change in diagnosis. This has implications both for counseling of patients and families, as well as decision-making around initial operative management. Larger studies are needed to confirm these findings and to help facilitate development of guidelines for recommending prompt and appropriate surgical management of these patients. Thank you, and I'd be happy to take questions.
We have time for one question.
I have a question for you, Amy.
Yes.
Given the high rate of change in diagnosis, has that suggested to you that you should alter your surgical approach in these patients?
Yes, I think so. There have been studies looking at performing a diverting ileostomy in patients that have an uncertain diagnosis, and that may be a more appropriate first step in patients that, in whom we're unclear. The question is, how long do we wait, and when can we be sure that ulcerative colitis is actually ulcerative colitis in children that have been diagnosed so early? But thank you.
Thank you.
Thank you.
The next abstract presented will be Effects of Parental Activation in Children with Intestinal Failure, to be presented by Dr. Chin Onwubiko from the University of Alabama, Birmingham.
Thank you. We have no disclosures. Patient activation relates the patient's knowledge, skill, and confidence in taking care of their health problems. And in the adult population has been shown to have patients with higher activation scores have better outcomes. So we sought to look at the activation scores of their parents to the outcomes of intestinal failure patients. To do that, we looked at patients in our intestinal rehab registry and had the parents take a literacy test, which looked at their ability to read and interpret medication labels and food labels, and additionally gave them the activation measurement. The literacy test was on an 8-point scale ranging from 0 to 8. Median score was 6. The raw PAM score was 81, with most of the patients getting in the range between 50 and 100. Using the raw score, we then created a PAM level, and we see that 95% of our patients had higher activation levels. So we looked specifically at those patients who were highly activated, which means a PAM score of 4, and looked at outcomes related to intestinal failure. And though not significant, we see that the higher activation score related to lower CVL infections, and that the patients' parents who had higher activation scores also had better health literacy. So we see that there may be some association with literacy and activation, in addition activation with CVL infections. The overall activation and literacy scores show that these are interrelated in the overall care of patients with complex problems, including intestinal failure. Those patients who are highly activated may be do so due to the need of the parents to be so, and then also potential selection bias. Thank you.
Thank you. This paper is open for discussion. Chin, I don't know the parental activation score very well. Is that something that you've seen to be correlated with underlying care provider education, socioeconomic status, et cetera? And does that have some role here as well?
Right, and that's part of the reason we looked at the literacy to see if there was kind of some relation to it, because most of the literacy things that we look at nowadays are based on how much the patients know, but sometimes people can be really poorly literate but really involved in their patient or their child's care and want to do what's right, they just may not know how. So we looked at the literacy to kind of help figure out which actually is more important, and that's something we're going to continue to look at.
Okay, thank you.
Thank you.
Our next topic is outcomes and burden of disease in adolescents with neonatal onset short bowel syndrome. Presenter is Dr. Han, and co-authors are Nell, Henry, Hong, Han, Staffa, Modi, and Jaksik.
All right. Thank you for the opportunity to present. We have no disclosures. While survival is now reported at greater than 90% in patients with neonatal onset short bowel syndrome, not much is known about outcomes of older children with this now chronic disease. Hence, we sought to describe long-term outcomes, including mortality and the ability to wean off PN, parenteral nutrition, while determining disease-associated morbidity and burden in adolescents with neonatal onset short bowel syndrome. We conducted a review of 70 adolescents 10 to 19 years old seen in care from 2009 to 2018. Neonatal onset short bowel syndrome was defined by loss of bowel and PN dependence for greater than 90 days. Median age at last follow-up for these adolescents was 15 years. Mortality was 0% in these adolescents, and 73% were able to achieve complete enteral autonomy without transplant. Another 6 patients underwent transplant and subsequently weaned off PN. This Kaplan-Meier curve demonstrates that the 10-year probability of weaning from PN without transplantation was 70%. What's remarkable is that 3 patients went on to wean PN after 6 years of rehabilitation and another 4 after 10 years of care. High rates of intestinal failure associated liver disease, bacterial overgrowth, cholelithiasis, nephrocalcinosis, and metabolic bone disease was seen in this cohort. When observing yearly disease burden, patients on PN had a greater number of diagnostic tests, outpatient visits, and prescription medications from their counterparts who achieved enteral autonomy. And while disease burden was high, it's notable and very encouraging to see that 100%, or all near 100%, of these patients went on to achieve educational attainment. So in conclusion, short bowel adolescents survival in these cohorts is excellent. We want to highlight that achievement of enteral autonomy is attainable in the majority of those reaching adolescence, with 73% weaning from parental nutrition with long-term transplant-free rehabilitation. Short bowel-associated morbidity and disease burden remains substantial in these adolescents, and the higher rate of these comorbidities suggests that routine surveillance with DEXA scans, abdominal ultrasound, and laboratory testing may be beneficial. Thank you.
Paper is open for discussion. Thank you very much.
All right, thank you.
Next abstract for discussion is, does following a management algorithm for adhesive small bowel obstruction decrease the incidence of bowel loss? To be presented by Dr. Brittany Johnson from the group at Texas Children's Hospital.
Thank you for the honor of the podium. We have no disclosures. Variability exists in the management of pediatric adhesive small bowel obstruction, and there's increased risk when operation is delayed. The purpose of this study was to develop and test the effectiveness of a clinical management algorithm. A clinical management algorithm was developed. We completed a retrospective review of patients with small bowel obstruction, comparing their management to the proposed algorithm. We evaluated bowel resection and time to OR to evaluate if the algorithm would have improved outcomes. The algorithm classified patients based on initial abdominal X-ray and clinical presentation into 3 categories: free air and clinical concern for ischemia, typical abdominal X-ray for obstruction, and atypical abdominal X-ray for obstruction. There were 31 patients who met criteria for urgent operation, with 100% following to the OR. Bowel resection was required in a third. There were 99 patients who presented with the typical abdominal X-ray such as this. The algorithm called for a trial of non-operative management, and by 24 hours, a decision to be made for continued operation versus continued non-operative management. 40% of patients met criteria, and of those, 33% were taken to the OR. Bowel resection would have been lower in those patients who would have followed the algorithm. 77 patients presented with atypical abdominal X-rays with a paucity of gas. The algorithm recommended obtaining additional imaging in these patients to clarify the diagnosis. 45% of patients received this imaging, and 60% had concerning findings. Of those, 67% were taken to the OR, and bowel resection between these 2 groups was similar. In all patients with initial non-operative management, had the algorithm been followed, we found that patients would have received bowel resection about half of the time. However, following adjustment for fever, tachycardia, and leukocytosis, this significance no longer held true. However, we did find that decision time to OR from last imaging would have been 4 times faster if the patients would have followed the algorithm. So in conclusion, a management algorithm for small bowel obstruction may be helpful in decreasing variation in care and improve outcomes. Our algorithm may prove that it can decrease delays to the operating room. So our next steps are altering our algorithm and then prospective validation. Thank you, and I'll take any questions.
Thank you. This paper is open for discussion. Dr. Cowles.
Hi, Bob Cowles from New Haven. I think this is a great study. I think you were forced kind of to present it quickly because it's a quick shot. So I'm not sure I understood all of it. But I would think that some patients who have delayed management may be patients who are identified as, I don't know, maybe a difficult abdomen, previously repaired omphalocele. That may be the last abdomen you want to go into. And you may really kind of be holding back on taking them to the OR. So I wonder how that, the previous surgery and, maybe the perceived difficulty of the adhesiolysis, how that will translate into the operative delay, and that those more difficult patients may also be at higher risk for bowel loss anyway.
Yes.
I'm not sure if I'm coming across right.
Yes, no, I understand your question. So I think the first part of it, what you're asking, is more of like a clinical decision-making with the surgeon. So I think with the algorithm, it might be difficult to tease that out. At least what I'm understanding you to say is that if there's a patient that might be higher risk, that the attending or the faculty may decide that, or you just have a little bit of hesitancy for taking that patient. I don't think that we could include that in the algorithm. I think that what you would have to take account into with that case is just considering the risk for the child, because like you're saying, yes, if you do operate, you are going to increase the risk that you'll have like an inadvertent bowel injury, or you're subjecting that child to another operation. So I think it'll just be more of a decision to, if you wait too long, that that child is at higher risk, that you're still going to get that bowel loss. So just making the decision to go ahead and operate.
Thank you. Next paper is lipocalin-2 increases intestinal permeability and reduces adaption through changes in the gut microbiome in short bowel syndrome, presented by Dr. Zhang, and co-authors are Wang, O'Hare, Parental, Fulton, Sodi, Hackham, Sear, and Elish. Sorry.
Thank you. Thanks, Dr. Modi and Meier. Good afternoon, everyone. It's a great honor to be here to present our study on short bowel syndrome. So short bowel syndrome is a major cause of morbidity and mortality following surgery of necrotizing colitis, atresia, and gastroschisis. So it was reported that intestinal dysbiosis is associated with poor intestinal adaptation in short bowel syndrome. So we are trying to find some target to treat the disease. Lipocalin-2, we call alsin-2 here for short, is antimicrobial protein in the gut. But to our surprise, we find out that our alsin-2 knockout mice, who received 75% of small bowel resection, had a better intestinal adaptation. They lost less body weight and had less intestinal permeability than a wild-type short bowel mice. Therefore, we hypothesized that alsin-2 may increase the intestinal dysbiosis and decrease intestinal adaptation. In order to study the disease, we made a mouse model of short bowel syndrome in wild type and alsin-2 knockout mice. After post-W7, we sacrificed the short bowel mice and collect the feces for fecal transplantation in germ-free mice. At post-transplant day 7, we find out that the germ-free mice who received their fecal transplant from the alsin-2 short bowel mice, they had a better intestinal adaptation. They gained 2% of their original body weight, had less intestinal permeability, and have relatively longer villi in jejunum. But the germ-free mice who received the fecal transplant from the wild-type short bowel mice, they lost 1% of their original body weight, had a higher intestinal permeability, and a relatively shorter villi in jejunum. Here we can conclude that alsin-2 exacerbates intestinal dysbiosis after small bowel resection, which will decrease the intestinal adaptation. Neutralizing the alsin-2 may be a novel therapeutic target for improve the intestinal adaptation in short bowel syndrome. Thank you for your attention. I'm happy to take any questions.
Paper's open for discussion.
I wonder if you're transplanting not just the microbiome, but also potentially paracrine hormones or other factors from the lumen of the colon of the mice. And so I wonder, to test that, have you considered maybe rescuing the wild type transplants with just good bacteria, if that's possible?
Oh, that's a really great question. Thanks to Dr. Modi. I think, yes, I think instead of like the microbiome in the gut, I believe there's a lot of things in the gut. So we haven't done like the hormone, like what kind of the level of the molecules really testing the stool. But I think that will be a real help us to understand other than microbiome, what we affect the when we do the fecal transplantation, what will or will affect the mice as well.
Thank you very much.
Thank you.
So this session is dedicated to Dr. Ide Smith, who was an organizing member of APSA responsible for the membership invitations at our organization's inception. This video tribute was prepared by Drs. Sam Hahn and Jamie Nell from Boston Children's Hospital.
After graduating from medical school and surgical residency at Johns Hopkins University, Dr. Ide Smith went on to complete his pediatric surgery fellowship at Boston Children's Hospital in 1956. He trained under Dr. Robert E. Gross before establishing his own pediatric surgery practice and devoting a life to educating future generations of pediatric surgeons. Dr. Smith's impact on pediatric surgeons reached far and wide and included Dr. Stephen Jolly, Dr. Gary Hartman, and Dr. James Carson while serving as program director at the Children's Hospital of Oklahoma City.
Dr. Ide Smith served as Surgeon-in-Chief of Children's Mercy Hospital in Kansas City from 1963 to 1968, before his tenure as the Chief of Pediatric Surgery at the Children's Hospital of Oklahoma City in 1968 to 1987. His commitment to education led him to step out of retirement and spent his last 5 years of practice as the chair of the Pediatric Surgery Division at the UT Southwestern Medical Center until 1992.
No medical student, fellow, or resident was ever too unimportant to have escaped his consideration. His lessons, imparted in his usual soft-spoken and humble demeanor, were invaluable and had an enduring impact on those fortunate enough to be present. Dr. Smith was involved in the initiation of the pediatric surgery training program here at UT Southwestern. This fellowship, of which I am a graduate, in place since 1994, is a direct consequence of Dr. Smith's commitment to education. My interactions with Dr. Smith were during the months I spent at Children's Medical Center as a general surgery resident. I had a keen interest in pediatric surgery, but little idea how my convoluted career would unfold. I was intrigued by Dr. Smith's devotion to surgical oncology, particularly his commitment to the care of those with neuroblastoma. His extensive and comprehensive neuroblastoma work with the pediatric oncology group speaks for itself. My career as a pediatric surgeon, as well as my own interest in surgical oncology, were inspired by my interaction with Dr. Smith during those later years of his career.
Dr. Ide Smith passed away on August 6, 2003. We remember Dr. Ide Smith for his contributions to the field of pediatric surgical oncology, including his dedication to the Pediatric Oncology Group and the study of neuroblastoma.
We also honor him today for his humility and passion in educating students, residents, and future pediatric surgeons. We'd like to thank Dr. Ide Smith during this 50th anniversary APSA meeting for his many contributions to the field of pediatric surgery.
The next presentation is More is Less, the Advantages of Performing Combined Laparoscopic Cholecystectomy and ERCP for Pediatric Choledocholithiasis, to be presented by Dr. Kristen G. From the Children's Hospital, Los Angeles.
Thank you for the opportunity to present our work. We have no disclosures. Complicated biliary disease is on the rise in pediatric patients. Currently, the standard treatment for choledocholithiasis involves an ERCP and a laparoscopic cholecystectomy as two separate procedures, which involves two anesthetics and therefore two inductions. And we know that exposure to anesthesia should be minimized in children. Therefore, we hypothesize that a concurrent laparoscopic cholecystectomy and ERCP is feasible in the pediatric population, and it would decrease costs without increasing procedural risk. We did a retrospective chart review over 5 years to identify all cases of pediatric choledocholithiasis at our institution, and our patients were stratified into 2 cohorts. The first had an ERCP and a lap chole under a single anesthetic, of which there were 14 patients, and then we had patients who had 2 separate procedures. We collected demographic and clinical data, as well as imaging and laboratory findings, outcomes, and costs. There was no difference in age, gender, or ethnicity between any of our groups. There was also no difference in the total anesthesia length, no difference in the complications, and no difference in the postoperative ED visits. We did, however, see a significant decrease in the cost of stay in our patients who had a concurrent procedure. Therefore, a concurrent ERCP and laparoscopic cholecystectomy is feasible to treat pediatric choledocholithiasis, and a concurrent procedure is associated with a significantly decreased cost of stay without an increase in complication rate or anesthesia time. Thank you, and I'd be happy to take any questions.
This paper is open for discussion. Dr. Cowles.
Hi, Bob Cowles from New Haven. How would you recommend it go? Do you think it should go lap chole first or ERCP first?
The ERCP goes first when we do this.
And I guess along those lines, were there any difficulties with air insufflation, and did that make the lap chole a little bit more difficult?
We didn't see any difference in our operative times when we looked at this, so I don't think that there was a huge complication rate from that.
And then I guess the only other question or comment is, would it make sense to do, I guess maybe your cholangiogram would get contrast into the ducts, but could you potentially propose to do the lap chole in a cholangiogram, and only in those cases where there appeared to be a retained stone, then do the ERCP, thereby saving some proportion of patients maybe from having an ERCP first? Thank you.
Yeah, that's a good question and something that we could look at. Some of these patients that were not included in this study did have an EUS first, and when there was no stone found, they didn't go forward with the ERCP, and then we did the lap chole, but that would be an interesting way to sort of flip-flop it.
Thank you, Linda. Let me just follow up on that. What was your indication for ERCP, and what was your negative ERCP rate in those patients?
So the indication for ERCP were patients that had an elevated total and direct bilirubin, as well as evidence on ultrasound imaging of a stone in the common duct, either a dilated common duct or a stone that was found on the ultrasound. We did not include any of the patients in this study who had just an EUS that was negative and then did not go on to have an ERCP. So all the patients that were included in the study as a concurrent procedure actually had a stone and an ERCP.
So then the patients who had ERCP also had an EUS?
Yes.
And is that time that was included in your study?
Mm-hmm.
And do you take patients with elevated direct hyperbilirubinemia to the OR for your lap choles? Is there any level at which you think they need to have their duct decompressed before they go to the OR?
And since we do them concurrently, we don't.
Very quick question. Who's doing your ERCPs? Do you have adult gastroenterologists, or is it pediatric gastroenterologists?
We have 2 pediatric gastroenterologists.
You're very lucky. Thank you very much.
Thank you.
Next paper is...
It's still me.
Oh, well, stay with us for a moment. Yeah. Normalization of serum lipase levels versus resolution of abdominal pain, a comparison of preoperative management in children with biliary pancreatitis. Dr. G is presenting again, and the co-authors are Dr. Rosenberg and Dr. Kim.
Thank you very much. I have not gained any new disclosures. So controversy exists over the timing of a laparoscopic cholecystectomy in pediatric patients with biliary pancreatitis. Some patients wait for the resolution of abdominal pain, while others will trend lipase levels until normalization, and there's a paucity of data in pediatric patients to support either practice. Trending lipase levels until normalization can take time. So we hypothesize that the resolution of abdominal pain is equivalent in outcomes to awaiting normalization of lipase levels in patients undergoing a cholecystectomy for biliary pancreatitis. We did a retrospective chart review over 10 years. We had 74 patients that met inclusion, 29 that had their lipase levels trended until normalization, and 45 that underwent a laparoscopic cholecystectomy as soon as their abdominal pain resolved. We collected demographics, serum lipase levels, postoperative complications, cost of stay, readmissions, and returns to the emergency department. There was no difference in age, gender, or ethnicity between either of our groups. More importantly, there was no difference in operative time or post-operative complications between either of our groups. The patients that had their lipase levels trended had a significantly higher number of serum lipase levels drawn. They were also significantly more likely to require preoperative TPN. They had a longer time to diet in days, a longer total length of stay, and importantly, a much higher cost of stay when compared to patients that underwent a laparoscopic cholecystectomy as soon as their abdominal pain resolved. So proceeding with a cholecystectomy after resolution of abdominal pain is equivalent in outcomes to trending lipase levels, and a cholecystectomy after resolution of abdominal pain is more cost-effective with a decreased length of stay and a decreased need for preoperative TPN. Thank you, and I'd be happy to take any questions.
You really try to get your biliary patients out of the hospital quickly, it looks like. Let me ask you something. Why don't we just operate on the patients right away if it doesn't really matter? Does the abdominal pain per se really make a difference, or could we just operate on them?
That's a good question. So none of the patients in this study had a preoperative ERCP, but I do think that it's important when you're thinking about retained stones that a patient has resolution of abdominal pain prior to taking them to the OR in case you need to do an intervention.
One other question. I guess, how did you define these patient populations in this retrospective study? Was it simply the fact that they had multiple lipase levels checked, or was there documentation suggesting that somebody was waiting for a lipase level below some number to operate?
So both. If a patient had multiple lipase levels drawn all the way across until normalization, their charts were checked, all their notes were checked to see if they could be included in the group that was trending lipase levels. And usually there's something in one of their notes that says something about it.
Okay.
Thank you.
Thank you.
The next paper is biliary dyskinesia sufficient to accept the risks of elective cholecystectomy in the pediatric population, to be presented by Dr. Bayouth and the group from East Carolina University.
Thank you for the opportunity to present. We have no disclosures. Biliary dyskinesia negatively impacts the quality of life in children, and while elective cholecystectomy can provide immediate and long-term symptom relief, not all pediatric surgeons offer this, commonly citing presumed operative risk without guaranteed benefit. The goal of our study was to evaluate the postoperative outcomes between our biliary dyskinesia patients and our all other acceptable indications for cholecystectomy. To do this, we retrospectively reviewed the charts of children ages 5 to 17 who underwent laparoscopic cholecystectomy at our institution between the years of 2010 and 2016. An analysis of variance was conducted to determine whether there were significant differences in length of stay by preoperative diagnosis, and a chi-square test was conducted to examine whether complications and postoperative diagnosis by pathology were independent of preoperative diagnosis. We looked at 119 patients. The most common indication for cholecystectomy was biliary dyskinesia, followed by symptomatic cholelithiasis and cholelithiasis in the setting of sickle cell disease. Pathologic diagnosis of chronic cholecystitis was present in 100% of the biliary dyskinesia patient specimens and a large majority of the other gallbladder disease group. The complication rate and hospital length of stay were lower in the biliary dyskinesia group. There were 4 patients that suffered complications. Only one of these was a patient with biliary dyskinesia, and this complication was related to a concurrent appendectomy, and this was bleeding at the appendiceal stump that required reoperation. The remaining 3 were in the other gallbladder disease group. Only one patient required conversion to open, and this was after an intraoperative cholangiogram identified a right posterior sectoral duct, and due to the aberrant anatomy and the need for open procedure for reconstruction, we converted to open. However, the subsequent postoperative course was complicated by a bile leak requiring revision of the anastomosis. The 3rd patient had an extended hospital stay due to postoperative sickle cell pain crisis, and the final patient had bleeding at a concurrent splenectomy site that required repeat transfusions. So in summary, we can conclude that biliary dyskinesia is a pathologically significant disease that has a very little operative morbidity with laparoscopic cholecystectomy, and this should be offered in the treatment of symptomatic biliary dyskinesia. Thank you for your attention. I'd be happy to take any questions.
We have time for one very quick question.
I have a question. How do you define biliary dyskinesia, and how many patients came back to you a few months later with the same symptoms?
We defined it as the patients who had HIDA scan with less than 35% ejection fraction and or pain on cholecystokinin injection. We had, as far as follow-up with symptom resolution, we saw all of our patients 4 weeks post. There were none that I saw in review of the records that came back to us directly, but there were some with other abdominal pain symptoms that saw pediatric GI.
Thank you. Moving right along, next paper is pain resolution and glycemic control in pediatric patients after total pancreatectomy with islet cell autotransplantation for chronic pancreatitis, presented by Dr. Siddell. Looks here, that's someone else, but Dr. Siddell is presenting. Other authors are Filman, Kajak, Golbeska, Bahul, Para, and so forth. Sorry, I don't want to take your time away.
Okay. Chronic pancreatitis in, advancing here. Chronic pancreatitis in pediatric patients is often associated with genetic mutations such as PRSS1, CFTR, or SPINK1. The patients can develop opioid dependence and exocrine endocrine insufficiency, and these children often face frequent hospitalizations and miss a lot of school and other activities. Total pancreatectomy with islet autotransplantation can achieve good pain control for these patients, and they can often maintain good glycemic control with some insulin independence. So in our series, we have 42 adult and pediatric patients in the last 10 years, and since our pediatric program began in 2012, we have 11 patients, median age of 16 with a range up to 21. Those older patients were patients who we'd been following for a few years. The median BMI was 20 and follow-up of 36 months. We have not lost any to follow-up. Most of these patients had pain for up to 4 years prior to surgery. And similar to other studies, we had about 2/3 to 3/4 who had a PRSS1 or CFTR mutation. So as far as opioid requirement, 100% had some opioid requirement before surgery, either intermittent or daily, and then post-operatively, most of our patients came off of all opioids. We have 2 patients who've had some degree of chronic opioid dependence, one nearly daily, and the other one at 3 years out has a chronic incisional non-pancreatic pain. This does not account for all of the patients because we're still following them. With respect to glycemic control, only one patient was on any insulin preoperatively, and postoperatively, by 6 months, 55% had good glycemic control and required no insulin at all. And at 1 year, with 9 of the 11 patients that we have out to 1 year, 67% had no insulin requirement at all. Factors that contribute to insulin independence seem to be, these are the 2 main ones in our study. BMI, lower BMI is associated with decreased insulin independence, and a higher islet cell yield at the time of the pancreatectomy is also associated with increased independence from insulin long term. So in conclusion, total pancreatectomy provides good pain control and resolution of pain for patients with chronic pancreatitis. I did mention the one patient who still has long-term pain. We have good preservation of endogenous beta cell function, and a lot of these patients have had insulin independence. And then the main factors are associated with insulin independence or shorter duration of chronic pancreatitis before going to total pancreatectomy with islet autotransplantation, a higher islet cell mass that's transplanted. We often see that in the younger patients compared to the older patients, and a lower BMI. So the more active our patients were both preoperatively and postoperatively, the more likely they were to have insulin independence.
Thank you. Time for one question.
I'm curious why the insulin independence increased over time. What do you think the mechanism for that is? Is that a known issue with islet cell transplantation, or?
That's a very good question. I don't know the answer to why over time. We've been very cautious weaning the insulin. So To be honest, most of our young patients are on 4 or 5 units of Lantus a day, and we very slowly wean it. So a lot of it has to do with the way our study has been planned.
Thank you.
The next paper is Temporary Gastric Electrical Stimulation in Children with Gastroparesis Predicts Long-Term Success, to be presented by Dr. Malik and the group from University of Florida.
Thank you for the opportunity to present. We have no disclosures. So gastroparesis is a poorly understood condition that has limited effective medical therapies. Gastric electrical stimulation is one of the forms of surgical management that is available and has shown to be beneficial in appropriately selected patients. However, patient selection for stimulation remains challenging, so our study aims to look at the usefulness of temporary gastric electrical stimulation to help in the selection of patients for long-term therapy. We looked at 140 patients who underwent temporary stimulation, and based on their symptom response, we categorized them as 99 responders and 41 as non-responders. Overall, the two groups were very similar, but they differed in a few key characteristics. Responders tended to be older. Responders tended to have a higher incidence of rheumatologic and autonomic issues. They tended to have a higher use of antiemetics for symptom control, suggesting worse symptoms. And then they had a significant decrease in post-total symptom score after stimulation. When we looked at the cardinal symptoms of gastroparesis, which include nausea, emesis, satiety, bloating, and pain, the non-responders and responders tended to be similar in their presentation, except for pain, with a higher percentage of responders presenting with pain. Additionally, looking at total symptom scores before temporary stimulator implant, responders and non-responders did not differ in their presentation. When we looked at total symptom scores immediately after temporary trial stimulation, responders showed a significant decrease in those symptom scores. And then looking at long-term symptom relief over approximately 2 years, approximately 76% of responders experienced significant symptom relief. So temporary gastric electrical stimulation can help in distinguishing which patients should get implants, and it can also help predict the long-term success. Responders tended to be older, they had a higher incidence of rheumatologic and autonomic issues, and they needed more medications prior to implant. Future studies are being done to blind subjects during this trial to continue to refine our selection process. Thank you for the opportunity to present.
How long do you do that temporary stimulation?
It can be there for up to 4 to 6 weeks.
I see. Okay. Any other questions?
Yeah. Can I ask, I'm interested in the group of responders that didn't ultimately respond, that 20%. Is there something that we can do to make that number lower?
So those are what the future studies are looking at, but overall, just continue to blind patients and also.
And the temporary stimulator is a mucosal-based device versus the permanent one, which I assume is a surgically implanted seromuscular device. Is that Salim's nodding?
Yes.
Is there perhaps a difference in that could lead to this false positive?
That could be, yes.
She did a great job.
But yeah, so those are mucosal versus seromuscular. So there's a difference between. So there's a difference between that, the seromuscular and the mucosal stimulation. But also the 24% who eventually in 2 years didn't respond, had to have their stimulators explanted. Those all had responded initially. So as opposed to the adult studies, which shows about a 50% initial success rate when you implant stimulators without any temporary trials, we had a 100% initial success rate. 2 of them had to get explanted at 6 months, 4 of them at about 9 months, and at about 2 years, we're down to about 20 of them, 24 had to get explanted for a variety of reasons. So we still had a 76% long-term success rate, which we thought was good with that.
Great, thank you. For transcription, that was Dr. Islam from Florida.
Thank you.
Thank you very much.
Next paper is implementation of a pediatric enhanced recovery pathway, decreases narcotic utilization and shortens time to full feeding, presented by Dr. Phillips. And I have to read you the authors because there's as many institutions as authors. Maves, Concetta, Luper, Pittenger, Hans, McLean, Hayes Jordan, and Adamson.
I want to
think my slides are the next ones. There we go. Thank you for allowing us to present. We have no disclosures. Enhanced recovery after surgery pathways are a standardized approach to preoperative, intraoperative, and postoperative care of patients undergoing surgery. They're well established in adults, but there's very little data about their implementation or effectiveness in children. In 2016, we implemented an enhanced recovery pathway for pediatric patients undergoing surgery for inflammatory bowel disease. We standardized their pre-op fasting requirements, their intra-op opioid and fluid administration, as well as their post-op feeding, catheter and tube management, and their multimodal pain medications. We then did a single institution retrospective review of our patients before and after implementation of our enhanced recovery pathway and compared the two groups. We identified 28 patients managed with our enhanced recovery pathway and 23 patients prior to implementation. We found that they were similar demographically and in the length of time for surgery as well as the type of procedure that they underwent. We saw a significantly higher ASA score in our pre-implementation cohort, which we did not feel was clinically significant. And then we saw an increase in the use of regional anesthesia, which we was part of our protocol and we expected to find. When we looked at their outcomes, we saw a trend toward a decreased length of stay, but we saw a significant reduction in time to full enteral feeding, as well as their daily floor morphine equivalent usage. So when we standardized it for milligrams per kilogram per day, we used about a third of the opioids that we were using prior to implementation, without an increase in returns to the OR, returns to the ER, or readmissions. So in conclusion, we feel that enhanced recovery pathways after surgery for pediatric patients with inflammatory bowel disease are safe and that they can decrease the time to full feeding as well as opioid utilization. Thank you, and I'm happy to answer any questions.
Paper is open for discussion. Have you looked at how many folks actually followed the protocol, or did you have folks that were not following the protocol because they were not comfortable?
So when we looked at compliance, we were, I don't have the numbers as far as percentages, but our pathway was pretty straightforward, and it was a small group of patients. That's why we started with our IBD patients. And so compliance was very good. I don't have the exact number, but there were very few patients who didn't have the protocol applied.
Thank you.
Thanks.
The next paper is Cost-Effectiveness Analysis of the Surgical Management of Infants Under 1 Year of Age with Feeding Difficulties, to be presented by Dr. Yu from Texas Children's Hospital.
Thank you for the opportunity to present. We have nothing to disclose. Gastroesophageal reflux disease has a large economic impact on healthcare. Traditional surgical treatment for infants with this problem has been fundoplication with gastrostomy. Recently, gastrojejunostomy has been an alternative that avoids a major anatomic and physiologic altering procedure, but may adversely affect quality of life due to frequent malfunction. The purpose of this study is to compare the cost effectiveness of different management interventions. Patients under 1 year of age with feeding difficulty requiring gastrostomy were prospectively enrolled. A validated GERD symptom severity questionnaire and a quality of life assessment tool were administered at the time of enrollment and at 1 month and every 6 months thereafter. We also collected resource utilization and cost data. We calculated quality-adjusted life months, QALMs, from the utility scores using the formula proposed by Sassi et al. The decision tree model depicts each management strategy and any crossovers during the study period. The incremental cost-effectiveness ratio, ICER, was computed to compare cost-effectiveness across management strategies. We also conducted a sensitivity analysis to address variability in calculations. 51 patients were enrolled. Overall GERD symptom scores significantly improved over time from 173 to 18 at 1 year. Quality of life scores also significantly improved at 1 year. Resource utilization and total costs for the cohort are shown here. 47% of the patients had readmissions, totaling $1.4 million. GJ had significantly higher costs for diagnostic testing compared to G-tubes. Of the 50 patients who underwent gastrostomy, the majority improved with G-tube alone, and 6 patients eventually had their G-tubes removed. 6 required conversion to gastrojejunostomy for persistent symptoms, and 1 patient underwent fundoplication. Our decision tree model shows overall median cost of $22,144 and a gain of 6.3 qualms for the child over the duration of the study. With respect to G-tube only, conversion to gastrojejunostomy had an incremental cost effectiveness of $68,241 per qualm gained. On sensitivity analysis, this ICER included a negative range, which suggests this is a less effective strategy at a higher cost. In conclusion, gastrostomy alone is a cost-effective management strategy for infants with feeding difficulty. G-tube and GJ were both associated with improvements in quality of life and GERD symptoms. GJ patients, however, reported greater gains in qualms but incurred higher costs. A longer-term analysis and larger sample size are needed. Further assessment of willingness to pay for each additional qualm gained will help determine the value of care. Thank you. I'm happy to answer any questions.
This paper is open for discussion. Dr. Yu, could you comment on the role of fundoplication in this, if you studied it at all?
Yeah, so at our institution, we don't typically perform fundoplication, and especially in this age group, given the natural history of many normal infants have reflux symptoms. And over time, within that 1 year period in this young group, they do resolve, which is what we saw in our studies in terms of improvement in symptoms over time in that 1 year period. We did have one patient that had a gastrostomy tube performed at an outside facility, and as a rescue did have fundoplication performed at 11 and a half months of age. But with that sample size and data, it's hard to make any conclusions.
Thank you.
We're approaching the last quick shot, and we're actually on time, which I find amazing. So I want to really thank all the presenters that they really try to stay on time. The last paper, no pressure. Last paper, racial and ethnic disparities in the use of epidural analgesia and in children undergoing major abdominal surgery, presented by Dr. Ferguson, Chika Rodian, and folks from the University of Texas Health Center.
Thank you for the opportunity to present. We have no disclosures. Regional anesthesia has been linked to better patient outcomes. Racial and ethnic disparities have been reported in obstetric anesthesia. However, there are few data on this topic in the pediatric literature. We aimed to evaluate whether racial and ethnic disparities exist in the use of regional anesthesia in children. We conducted a retrospective review of pediatric patients who underwent major abdominal surgeries using FIS data. Epidural use was identified through pharmacy billing data. 48,167 patients were included. Of these, 7% received epidurals. Epidurals were more frequently utilized in older, male, non-Hispanic white patients who were not publicly insured. Younger children, females, minorities, and patients with public insurance received fewer epidurals. On this slide, row percentages are shown. And patients who underwent major hepatobiliary procedures received epidurals more often. Epidural use also increased over time. To determine whether disparities existed, we built a generalized linear model adjusting for the variables shown here with a random effect for hospital. Oh, sorry about that. Shown here. Age less than 1 was associated with 37% lower odds of receiving an epidural, and non-Hispanic Black race was associated with 14% reduced odds of receiving an epidural. Overall, odds of epidural use increased over time. Our study had several limitations. Epidural use was identified using billing data, which is subject to error, and our data did not allow us to determine if patients were offered epidurals but declined. Epidural use in children has increased over time. However, we found that non-Hispanic Black race was independently associated with decreased adjusted odds of epidural use. However, it's unclear whether this disparities results from physicians offering epidurals less frequently or parents declining epidurals more often. And further studies are needed to determine the factors driving this disparity.
So I guess the question is in your last slide. Is it the patients refusing based on bias, or is it physicians not giving because of bias?
It's unclear, and I believe in the obstetric literature, it's also unclear because a lot of it is observational. So there have been studies that have documented that non-Hispanic Black patients are more likely to be mistrustful of physicians based on research history, which I'm sure we're all aware of. And so that may be part of the problem, but there's definitely the possibility that physicians are not offering the epidurals to these patients more frequently.
Tag you, Melinda. Is it race-based or is it procedure-based? Did you look at the procedures?
We did also look at procedures. But
Awesome.
I limited it due to time.
Awesome.
But it was more frequently used in the major hepatobiliary procedures. This one is hard to see, but this is broken down by the severity scores, 1 through 4.
So it was not procedure related?
No, so it was more likely to be used, as we saw in the unadjusted score, was more likely to be used in hepatobiliary procedures, but this was independent of, the race was after adjusting for procedure.
And did I understand your statistics correctly that you assumed random effect from hospital? Because certainly in this town, there's not a randomization of socioeconomic status or race to hospital.
Not that it accounts for it as in randomization, but that hospital is included in it as, I don't know how to explain it, but hospital is included in the equation. And when we did look at it individually by hospital, and there was no significant difference amongst individual hospitals, but there's too few patients per hospital to really break it down that way.
Thank you.
Thank you.